Once the recording has now started, I am admitting everybody in who is in the waiting room. And so good morning, everybody. And again, we are just starting the meeting and letting people on in from the waiting in the lobby. And so please give us just a moment for everyone to join on in. This is the Dosage Administration and Clinical Practice Committee. I'm Dr. Dominic Zerlo, and I am with the New Mexico Department of Health, and we are here in order to help from an administrative standpoint with this meeting. The meeting chair is Ian Dunn, and with that, just as a reminder, because we are recording this, please remember to keep your language to be appropriate, as this will be posted up to our website for public viewing. And other than that, I turn it now on over to the chair, Ian Dunn. Ian, the meeting is yours.
Good morning, everyone. Thank you for taking time out of your Monday morning to be here. My name is Ian Dunn. I'm the chair of the Dosage Administration and Clinical Practice Committee. Today, we are going to be going over still our clinical roles, tightened to fit within that rulemaking to just kind of define what the responsibilities of the different roles would be. It's just building off of what we have been working on so far in regards to how we're going to set up the clinical roles and as well as the preparation. So with that in mind, I will go ahead and turn over to the department to mute and unmute while everyone gives an introduction on who they are, their relation to dosage administration and clinical practice, and any affiliations. And then please raise your hand at this time if you would like to participate in the meeting. You can also introduce yourself in the chat.
Kate, I haven't enabled your microphone.
Good morning, everyone. This is Kate Hawk. I'm in Santa Fe, and I've been a practitioner, a trauma therapist for 40 years, done all sorts of work with psychedelics, including harm reduction and ketamine-assisted therapy. And currently, I've been working with Scottsdale Research Institute in Arizona, doing, last week we did the group of 8 veterans with FDA phase 1 psilocybin mushroom research. So I'm really interested. I think we're looking at very important things today. Some of these things, it's easy to just have a discussion and all be in agreement on what the right answer is, but all the roles and qualifications of people who are going to do this work are really important. So glad we're here today. Thank you.
Thank you. And Chris, I've enabled your mic.
Good morning, everyone. Chris Piskowski here, veteran, Heroic Arts ambassador, and a facilitator in Colorado. And I'm just happy to be here. Thank you.
Thank you. And Brenda, I've enabled your mic.
Good morning, everyone. It's good to see everybody here. I am Brenda Burgard. I am chair of the education and training for psilocybin for the medical program here. Hey, thanks for all coming here, and I hope we have a really great meeting today. Thanks.
And Denali, I've enabled your mic.
Good morning, everyone. It was great to see some of you in the rulemaking hearing on Santa Fe last Friday. My name is Denali Wilson. I am the State Director of Strategic Support for the Healing Advocacy Fund, which is a nonprofit that supports state programs for psychedelic-assisted therapy with a focus on access and equity.
Thank you. And Sky, I have enabled your mic.
Good morning, everyone. I'm an investigative journalist covering the ongoing coverage of the legalization of psilocybin. I've been very excited for the progress everyone's making, and I am just so blessed to be here. Thank you. With the Santa Fe Reporter.
Alrighty, and that appears to be everyone. Thank you all for participating. Jorge, if you would go ahead and share the clinical rules document. Perfect. So you guys should recognize this document. It did go out, so let's just go ahead and go through it. So an important note before we define any of these, a single qualified individual should be allowed to fulfill multiple roles where scope, training, and credentialing allow. So clinician as defined, and you'll notice I had actually reversed the practitioner and clinician. That did not match as well with the NMAC. So they are now back to how we started, which was clinician and then practitioner versus the document that went out. It's a minor phonetic change, but in terms of what's actually here, as defined in NMAC 7.35.2.7, should be a licensed clinician acting within their scope of practice who has diagnostic authority. So their responsibilities are to identify potential candidates based on qualifying conditions, certify qualifying condition for entry into the program, and to share relevant diagnostic and clinical history with patient consent and in accordance with applicable privacy laws. Limitation certification does not constitute clinical clearance, not responsible for determining medical appropriateness, and recommendations to education and training are to establish minimum education, continuing education, and licensure requirements, and define the required competencies. So just starting off with that, how are we feeling? Any questions, comments, concerns, or things that we can discuss? Kate?
Hi. Yeah, I just want to have clarity on the pathways in which people can find their access to this program. Like, could it be through their primary care physician, or do there have to be some specialized identified clinicians here? I guess the primary care physician could be a licensed clinician, so that's a very broad label for clinicians then. Just want to make sure I understand that.
Yeah, so this could be their primary care provider. It could be their primary therapist. Anyone with diagnostic authority really could be the referring clinician to just say, hey, they have this diagnosis, and the board and department have decided that this could be beneficial for them. And then that's kind of where they would stop. I did see Dominic raise his hand, so he might have additional clarification.
Thank you, Ian. And that was why I raised my hand. So Kate, in this regard, this would be similar to the way the medical cannabis program acts. And this is to help keep that licensure on a federal level separate with regard to enrollment in the program. And what this would simply do is the licensed clinician who has that authority in their scope of practice would be able to refer those patients, essentially saying that they have the qualifying condition and that the qualifying condition allows for them to be entered into the program. And so, yes, this could be primary care. This could be someone else. It does not necessarily have to be someone who has specialization. However, we are going to want to ensure, and this is a part that is down in the lower portion, that they do have some education and continuing education with regard to psychedelics, specifically psilocybin. And it will be something that these individual clinicians will have to register with the department to show that they have those qualifications.
Okay. I guess I've got a question about that, because this is really about making sure they have a qualifying condition as a diagnosis. And of course, we'd like all the clinicians to understand how psychedelics are being offered here, but I'm just wondering if that's even necessary or if anybody could just talk to their, whoever they're already seeing.
Yeah, the idea would be is that the providers should have at least a minimum of education, especially because the majority of educational programs for providers right now do not include information about psychedelics or very minimal. So we just want to ensure that they would have a minimum amount of education. And that includes things such as continuing education, CMEs, that sort of a thing. And so those are some of the recommendations that education and training will need to determine.
Okay. So say somebody just goes to their doctor or nurse practitioner they're already seeing and they're interested in this, then that person would have to refer them to another person who, if that person didn't have that continuing education, they would need to find somebody who did and then refer that person?
Yes, just like any other specific condition, that is correct.
Okay, thank you.
All right, and then Catherine.
Good morning. Something that I think we might want to consider is adding an acronym before clinician so that it's specific to this program, like Psilocybin Medical Act, PMA clinician. I see that under practitioner, which I know we haven't gotten there yet, you do specify psychedelic. I just think we need to have some kind of a qualifier that specifies that they're part of this very specific program, and that then qualifies that they've taken whatever educational content we're going to require of them to make sure that they've got the basics, like what Kate was mentioning, that they have, something like that. Just something where we're adding, that would work. Certified, psilocybin certified clinician, just something that specifies the program. Thank you very much.
Yeah, and I am totally up to any like verbiage changes. So if someone has something better than psilocybin certified clinician, please do let me know. But I did see Denali's hand up.
Hi, okay, I might have gotten a little lost there. So I think I thought that the referring clinician, if that's what we're calling, or the certifying clinician, it did not have to be within the program, the scope of the program, because the practitioner was, but right, like, so if to Kate's question about primary care, right, or if we're thinking more in the behavioral health lens, right, your long time established therapist for individual therapy, or psych for med management, these are people that you're already interacting with that might not be within the scope of the program, but know that it exists and could make information available about the program. But I had before that question, I had another question about how this is going to interact with our end of life providers, and just the difference of diagnosis being maybe a little too limiting within that space, right? If there is a need to build out a separate care model or referral model, or whatever we end up calling these guidelines, understanding that end of life isn't a specific diagnosis, but right, like maybe it be that the person is already receiving palliative care, or there were some good ideas in the end of life committee meeting that happened last week in Albuquerque. So maybe someone with more expertise there could help map out if this would be limiting. I guess that's the first question. And if so, what the flexible solution would be to make sure that this works in end of life.
Yeah, so to answer your first question or second question, I deferred most clinical responsibilities, assigning pretty much the end of life care committee has full jurisdiction over that diagnosis, recognizing that it is substantially different from the other conditions. So in my view, and I have designated all of that to them because of their differences in how they're going to be treated. But in terms of, can you remind me what your first question was again? I'm sorry.
Yeah, sorry. I know that that's always the trouble with a compound question. I just was looking for clarification. I think Catherine had some ideas in the chat too of whether this first clinician, right, the first touch point in the system, whether that person does need to specifically be a part of the DOH program, or if, kind of like I think about maybe an example is medical aid in dying, right? You have a lot of people in this ecosystem in New Mexico, care ecosystem, who know that exists, do not provide the services, but are providing information about the services. That's kind of how I was imagining this role. But I think if we're requiring them to specifically be certified, maybe there's another administrative, like departmental reason that that's necessary. I'm just looking to understand that better.
Yeah, so in my mind, I hadn't imagined it being like a super complex or tedious process to become like a psilocybin certified clinician. In my mind, it was very similar to the medical cannabis program where they have to get registered so that they have access to BioTrack and can submit their applications, but not necessarily a full scope. But I will hear more from Dominic. I think he has more clarification.
Yeah, and actually, Catherine really expressed it very clearly and very well. It's along the same lines of what we had discussed even in previous things, that we just want to ensure that these clinicians have some understanding, that they know who, the patients, that they're referring them into a program and what the program is really about. We're not talking about it being a lengthy, long process, such as what facilitators and other individuals have to go through in, either Colorado or Oregon. We're really talking about, you have a couple of hours of either continuing education or of a class, and it could potentially even be simply an online asynchronous sort of a training that's provided. And then we have to determine exactly what those requirements are, but not looking at lengthy, long-term investments on the provider standpoint about having to go through multiple courses and things like that. But we need to ensure that they at least understand a little bit about psilocybin and what they're actually, certifying these patients for with enrollment into the program. It is not very different than what we are doing. We're not looking at a high bar on it. We're really looking at, does this clinician understand? And correct, Denali, not facilitation training. Simply, do you understand what psilocybin is about, the potentials for your patients, before you're just, certifying them for the program, as far as for having a condition for the program. So hopefully that helps. Yeah.
Perfect. And then I see Sky.
Hi, good morning. I'm a little confused, but I really appreciate Kate and Denali's and Catherine's remarks regarding physicians. When I, as a person, read psilocybin certified clinician, to me it doesn't say primary care doctor. And I understand that all primary care physicians should be versed in what psilocybin is. I agree with that, and it should be a really short program for them to just get to, my brain's not working this morning, I'm so sorry, get familiarized with what this is. On the other hand, I really believe that it would help if primary care was included with clinician, because if I go to the doctor and I say I have ABC going on, and he turns around and says, well, you might want to consider psilocybin, and he tells me all about it, I don't really view him as a clinician. I view him as my doctor. So then he would then refer me to the program, who then goes through a psilocybin certified clinician to get certified for the practitioner. It just seems to me, as the person on the other side and trying to finish this article, that it could be a little more clear. Can I get thoughts on that? That's really my question.
Yeah, so I'm not too strict on like semantics. So psilocybin certified clinician could be changed to just clinician. That's how it's written in the administrative code. However, we just wanted to recognize that there is a little bit of training before they're able to refer to the program. They should know what the program is before they're sending patients there. It's not meant to imply that they are providing the psilocybin services themselves. In my head, how I had always imagined it was you're already going to your therapist. Your therapist had done their registration process, and then you would just get deferred to a psilocybin, specialist area that would actually handle administration and that kind of thing. That way, that provider, let's say it is a primary care provider, and a physician, that way they don't have as much fear that the DEA is gonna take away their license for participating because they're just saying, here's what a program is. I'll go ahead and write you in. But a practitioner, a psychedelic therapist will actually take care of you, and they're the ones primarily working in the psilocybin space.
Yeah, I understand all that. I guess I don't know if it's semantics, as you said, but I think to me, if you want to say clinician, like somebody just put something in the chat, please let me refer to it. Who was it? Saying what a clinician could be, a primary care, a therapist, or whomever. I think they're maybe consider just spelling it out in parentheses so people understand it if this is going to go out to the public, because it's, to me, just a little thoughts. Everybody's thoughts would be great on this one. I'm kind of I feel like a stickler a little bit because an MD, perfect, DO, perfect. Yeah, those things I think would help being listed. Then, oh, okay, that's what that is. That's all. Thank you, Ian.
Yeah, no worries. And then Dominic?
Okay, and just to clarify a little for everybody, and Ian mentioned this is really simply what these positions are within the rule. This is not what individuals will necessarily call themselves or some of those other aspects. But for the rule, we have to define what the role is. And part of it, if you look at that definition, the important part is the individual who has diagnostic authority. So it's somebody who has licensure based upon their scope of practice and what their licensing board allows, who has diagnostic authority for these conditions. So it's not a laundry list of here are all of the licensures that can allow for it. Because we've been compiling that list, and I will say, and we've experienced this over the years in other programs, sometimes there ends up being a licensing board, for example, where it's missed, and then somebody from that board or somebody who has that particular license comes forward and says, hey, this is within my scope of practice. So we don't define that as far as doing a big list of all the different potential licenses in the rule. We keep it as this is within their scope of practice and allowed through their licensing board, those individuals who have the diagnostic authority. And then these different providers can then go through the process. And again, if we don't have them initially on the list, they can show us just where. We will do that research from a department standpoint to ensure that is accurate and add them on in. And so when we talk about these different terms, and it's the same as far as clinician, practitioner, facilitator, guide, journey person, whatever term, this is just the term for within the rule to define out that role. But somebody, for example, because we've heard from a lot of people that say that they like the term guide as an example for somebody who is sitting with someone going through the process. Other people don't like it for a variety of reasons, and they would prefer facilitator. Some people prefer the term facilitator for what we've got here calling a practitioner. So it's not so much about what individuals are going to call themselves. For the rule, it's about the role. And then how that gets education moving forward, because some of these points about who then will be able to do it, that's going to be a part of what goes out publicly from an educational standpoint, helping to work with various providers of different licensure types, of letting them know that, look, this is within your scope of practice, or it is not within scope of practice. And that's going to take time to develop and to actually have out there. So adding in these different items about, as far as what exactly, what degrees, what licensure, all of those sort of things, like Catherine, for example, has in the chat about a PhD as a prescribing doctor. Well, that would work already, for example, with a licensed clinical psychologist. So there they already have the PhD and they have the additional licensure with regard to being able to diagnose various conditions. And so it's thinking about those aspects, but that for the rules, the terms need to be very simple. And so that's why we have these as they are right now as proposal. But what people want to call themselves as they go out and they educate and they do that, it really is going to be dependent upon what they like. However, with that in mind, if there is another specific term that people can agree upon, we're perfectly fine with changing that for within the rule. Clinician, however, is within the statute. So that one we're leaving as is, just with regard to that first step, because that is part of the statute. So I hope that helps.
Yes, thank you so much. So Denali had a question or comment.
Yeah, I put a little more in the chat. I think it might just be helpful to ask if any of this language is going into regulations to get a perspective from your legal department about certification. It might just be better to use permit from the department's perspective in terms of the risk that the department takes on when you certify someone. You're saying this, you're implying that you've evaluated their skills as a clinician, and then that can just attach different liability. But I think Chris in your office will have some ideas about that. That's all.
Thankfully, so as long as the meat and bones is adhered to, the department has a lot of leeway with the semantics portion. So if it does come out, or Chris comes out and says that, oh, it's not good to use that word, they can change, certifying. They don't have to follow the recommendation down to like the letter. They just have to follow the guidance that it brings. So if that does become an issue, that would probably be handled internally. I'm not a lawyer, so I can't speak to that. But I do appreciate your insight. Does anyone else have, do you have a new question or comment, or is your hand just residual?
It's residual. Oh,
okay, no worries.
If I can figure out how to take it down here. Oh, there we go.
No worries. All right, so then we will go ahead and would there be letters like probably not, it would be my guess, because I don't know. That would be up to the department. But so what Sky put in chat was, would there be letters following like PCC, psilocybin certified clinician? I don't think so, but I will leave that to the department. I cannot speak for them.
Yeah, as far as that goes, we're not at that point yet. Again, this is to establish the rule. As far as those kinds of specifics, That's not something that we're at this point, but it probably would not. Again, we don't want to complicate it more and have people think that, oh, the psilocybin certified clinician is the person doing the facilitation, for example. These are very specific duties and job roles within there that go within the rule. And the idea is to ensure that we have as broad abilities for the various clinicians throughout the state so that there's good access with regard to it. However, if, for example, a clinician wants to say, hey, I have gone through the training that was required and I can certify individuals for the program as having a condition, then that is perfectly fine. That will be up to those individual providers.
Perfect, thank you. When we move on to our next definition, I went ahead and provided how things are defined in the rules in the chat, just so that we can, the definition of this one I trimmed down to just be the rules because we had a lot of deliberation, so I wanted to give more chance to add and to recreate instead of starting from a full practitioner. So the definition in the rule is an individual who is a licensed healthcare professional who is certified by the department to provide medical psilocybin integrative therapy, supervised guides, and who has completed department required trainings. Does anyone else think we need to add anything to the definition of a practitioner? All right, so seeing the scope is to conduct a comprehensive biopsychosocial assessment, review medical and psychiatric and substance use history, identify contraindications and medication interactions, evaluate risk for adverse psychological or physiological response, and create a safety plan, and to determine medical appropriateness for psilocybin treatment. Our responsibilities are to evaluate clinical appropriateness for psilocybin use, including but not limited to medication interactions, medical and mental health history, and a current functioning. If the patient is not appropriate, refer them to primary care provider or other appropriate treatment avenue. Use trauma-informed and culturally competent communication throughout the screening and treatment process. Assign a clinical support tier. Establish dosing parameters or considerations. Approve or defer participation based on safety. Denali, you raised your hand?
Hi, sorry. I maybe am responding to the wrong thing, but the question about definitions is the ones that you put in the chat.
Yes. So those are the
um,
definitions in the rule.
for practitioner too?
Yes.
Did we define practitioner? I think, well, maybe it would be helpful to hear from the department. I think my impression
You cut
last
out.
week was some of these terms are were not promulgated. They're being held as for further discussion. Because I do have feedback on these from both like a liability standpoint, and I think there were some important conversations that happened around the term guide, but I just want to get clarity maybe from the department that I think we're pausing on the promulgation of these specific roles other than clinician, because that's just the statutory. Yeah.
So just to answer that real quick, Denali, what's happening is the rule is still, depending upon what we get from the hearing officer, will still continue to move forward. However, in the next hearing on this specifically, we can adjust and change them as needed. This is the starting point. And so that's where the questions are, is what items potentially to change. Ian's presenting it as this is just what's in there at the moment. What do we need to potentially change on it? So that's the situation as it moves forward. It's that changes that in this area with regard to dosage administration, training and education, those rules are not finalized, and we simply adjust those definitions in each of those particular, the hearings that revolve around those. Does that make sense?
It does make sense. It does make sense. I think I have kind of extensive feedback on these definitions that I don't want to derail us from, but maybe most importantly, I think there are both cultural considerations that I've heard brought up in this committee and others about the term guide that I'd like for us to have a conversation about. And then also on guide, there are some liability implications if we're asking a practitioner to supervise them, that I think we want to think through. But I don't know if we want to have this conversation now or maybe table it. I think it's also relevant to the training and education committee, but defer to the chair and department about where best to have those conversations.
So for now, since we're focusing on the practitioner portion, if you would like to, what comments you have about that, we can begin there. And then when we get to guide, we can get to that as well.
Yeah, well, I think it's a little hard to move through quickly because I think they're pretty foundational about the roles of team members, right? But yeah, in general, there are going to be both care coverage and professional liability issues that are going to present major barriers to the viability of the program if we establish a supervisory relationship between a practitioner who is a licensed healthcare provider and a guide who, my understanding of the definition and conversations, right, maybe does not need to be a licensed healthcare provider. So I think that those relationships and teams that we're creating are really important to think through really carefully. So I'm a little reluctant to provide feedback that feels rushed, and yeah, I know that we're having ongoing conversations in many different places about liability, both well, insurance and liability, both from a care coverage perspective and professional liability, understanding that these are two foundational pieces of law that will dramatically impact access and equity within the program long term. So that's my, I don't know, kind of non-feedback. I'm sorry, Ian.
No worries. I do appreciate you taking the time to point out some of those things. On the contrary side, is if we are going to have guides be non-licensed individuals, then what we'll have to do is find some way to prevent wrongdoing. And I'm not saying that liability is necessarily the best option, but we do need some avenue. For a clinician or a practitioner, they both report to their respective licensing boards, and so I can ensure that they're doing most best practices. In terms of a guide, because they don't have a specific licensing board, we want to ensure that they have someone to report to. That way we can always hold accountability. What I don't want is for someone to just be able to get away with doing the wrong thing either. I'm not saying that that's like a problem that we're foreseeing, but I am saying maybe we do need to consider this liability portion as well. Sky had some comments.
Can you hear me? Okay, good. Is this a gray area? This is something I wanted to ask in one of the meetings recently. It might have been the end of life where we were talking about caregivers or guides. If facilitators and therapists and growers all need to be trained and licensed, how is it the guides, and maybe I'm misunderstanding, are not under the same umbrella? I would think it's either black or white. You're either licensed or you're not. So am I misunderstanding something?
No, so they would still be licensed from the Department of Health. The different issue was a healthcare provider, when they're licensed through a licensing board, have ethical obligations, moral obligations, and duties to their patient. We can try to create those from scratch within the department. However, oftentimes leaning on these existing institutions can be beneficial. I'm not saying that guides will have like no training and none of that. No, they'll still be trained and have to be licensed by the department. Their only area where they are a little bit freer is that they don't have licensure to any board or like they don't have a board of nursing or a board of physicians or that kind of thing.
When I hear the term guide, as I used to lead groups and I'm a retired intuitive counselor, I feel it's someone taking you through a journey. That's why I asked. Thank you.
Thank you. Kate?
Yeah, I just want clarification because you just said that guides would be licensed through the DOH, and with my understanding, there won't be any new licensing like what they have in Colorado. But I am wondering how it can work to have teams of people who have, licensed people or people with specialized skills, but not in the current, licensing system. So I'd like to have clarification, like when you just said, well, they will be licensed. Obviously, they have to be credentialed and recognized, but what might that look like?
So yeah, my point was more so where the licensure was from. So we defer a lot more, we give a lot more deference to licensed providers in the grounds that even if we don't make a specific rule to prohibit it, we can hold a licensed healthcare provider accountable via their ethical and moral obligations to their patients. When we are licensing, we have to set every rule and strategic, trying to predict what people are going to do wrong and then trying to prevent it versus institutions that have existed for decades. So that's where that cutoff was. And again, I'm not saying that that this is the way that it has to go, but I am saying what if we're going to change something, we need a reasonable change, something that we can say, okay, what is wrong here? Because that's the only way that we're going to kind of get through this rulemaking process. My point about the guides was just that they don't have a secondary institution. It was not that they were not licensed, and I'm sorry if I misspoke.
Okay, I'm glad we're taking time wrestling, and I'll keep asking questions. So, even if they're kind of fuzzy at this point, I'm glad we're continuing with clarification. Are we moving on to the guide section, or are we done with the section before that?
We're still in a little bit of discussion. I still see one more hand up, and then we can go ahead and move forward. Denali? Oh, did you still want to speak, Denali?
Yes, sorry, I unraised my hand instead of unmuting myself.
No worries.
Yeah, like Kate, I'm grateful that we're talking about these important details. I put in the chat what we'd recommended as an amendment, and I just want to say again that this doesn't address, I know and heard, and appreciate some of the concerns that were raised in other committees about the term guide itself and whether that's appropriate for us to reflect. But just setting that aside and thinking about both the potential risk that we are exposing people who are taking on this role and to clinicians and practitioners who are interacting with this role, the recommendation would be is trying to respond to two kind of concurrent problems. One, if we talk about supervision, we have potentially exposed people who are not healthcare providers and cannot receive medical malpractice insurance because they are not qualified to receive it. to medical malpractice claims. Also potential claims of unauthorized practice of medicine. So that's kind of really where the supervision piece is a problem. And I hear and really appreciate the desire, right? The reason that we write in supervision isn't because we want to give people complicated insurance problems. It's because we want to create patient safety. And so I think that knowing that there are these barriers, we really need to lean into our the education that we require people to complete, and continuing education to be like where safety is held. And our compliance officers that are operating within the department and are assessing safety and responding and tracking adverse events. And right, we've created a system in which the department has authority to respond to and address harm, but the supervision piece, I think, creates too much of a complicated problem for folks who are, intending to help people access healing. I'll say to another, right, to address what I hear, Ian, is your desire to uphold patient safety without creating what might be too complex insurance and liability issues. Maybe one requirement would be, this is something we've recommended to the department as well, is that, and it's pretty consistent across spaces, is that people carry sufficient insurance for whatever their role is. So if you require somebody to be operating in a space where they're insured, that, right, the idea being that a patient who is harmed is not going to be left without recourse. Those are just the off-the-cuff thoughts and ideas that I have lingering on this issue.
All right, so thank you. From the general vibe, I think we are switching over to guide. So we will go ahead and do that as well. Thank you so much, Denali. Yeah, I have been reading it. I do like the version that you provided in the chat. It would suffice with me, but I will listen to some other thoughts just to make sure I'm not making that decision, unilaterally. But Gregory?
Hey, pardon me for catching up. I had some stuff going on this morning. And I haven't had time to put all my thoughts on paper. But I thought we were in the camp of steering away from using the term guide. I know we're beholden to the language in the bill that was passed, and that's not going to change, but I was under the impression that we were going to find a less problematic way of interpreting that language as we moved into the rule of law. I don't want to drive down a massive tangent about why the term guide might be problematic or more importantly, inaccurate for what our clinicians and different types of practitioners and facilitators are doing. But unless you are singing my spirit through a trauma, walking me through in another realm, you are not a guide. You are some physical person in a room that's going to make sure that my life signs are okay, and that if I need to talk to somebody when I come back, there's somebody there. But if you're not I don't mean to get too esoteric, but if you're not actually guiding my spirit through Hades or wherever, we're appropriating some, not even language, just a type of action that can happen in the psychedelic realm. And forgive me if I don't think, I deeply respect this program, and I very much care about how it proceeds. But let's ask the questions before we put this in print.
All right. And then Dominic had some clarification.
Yeah, so I've mentioned this a few times and in other committees. We have been asking, and instead of continually having a debate of using guide or not using guide, what we've really asked is what term would people like to be utilized? That was only chosen originally as a placeholder because it seemed to, at the time when we first started the meetings, seemed to be the term that seemed to be most acceptable. What I'm hearing from everybody and have heard and have requested is what term would be best? We don't need to continue talking about the problems with the term guide. We just need to know what term to utilize so that we can adjust that within the rules. So I'm going to ask now for the people who are here, and you could just put it in the chat if you would like, what term do you think would be most appropriate for this particular position so that we can do that in moving forward and not continually just going back and saying guide is a problem, guide is a problem. We need to know what term people would like, and we need to come with sort of some kind of consensus on it. So what I would say is if people can put that in the chat, we can compile it. And then what we can go ahead and do is from that point, we can maybe in the next meeting or potentially even in one of the other committees say, here's a list that's been created and sort of move forward. I hope that helps. It just talking continually as far as from the semantics isn't helping us move forward with what we need. And we just want to make sure that this is not something that is set in stone. This was just something as a placeholder. So, and I am seeing facilitator quite a bit in the chat. I see some others, including guide, and also some others within there. So again, we'll make a list of those from those in the chat, and let's continue looking at what the actual aspects of what we're asking for these positions and not be hung up so much as far as just the name. So thank you, everybody.
Apologies
Alrighty.
if I ruffled.
No, you're good. Don't worry. We have to have the conversation. It was just we didn't cleanly transition from the last one to this one. I was gonna include that we can discuss the name because I know that Chris had brought that up at the last meeting and we didn't quite get to it. But yes, given what is currently most in the chat, we will go with facilitator. I think what could be a good idea, of course, I can't speak for the department, is just sending out basically all of these options. There it looks like guide facilitator, non-clinical facilitator, and clinician assistant, and just send it to the email blasts and have them vote. Because yeah, the term, at least from my perspective, the term we use is the least important part. The role that we assign them is far more important. But Gregory, did you have additional comments or did you leave your hand up? Oh, cool. All right, and then Chris?
Hi, Ian. Thank you. I just had one more thing on our last role. I wonder if that person should also evaluate, the support system and whether, the person has a support system capable of, and are ready to engage in that psilocybin treatment. Thank you. And then my other comment was about guide, but I think we've kind of beat that to death now. So
Perfect. Well, thank you for responding in the last meeting. I know we didn't get to that issue in more depth to talk about it, but I am glad that we were finally able to bring it up. So thank you, Chris. Catherine?
Yes. What concerns me about this is I'm seeing that the practitioner doesn't do any preparation and that the facilitator or guide, whatever we want to call that, is doing all the preparation. That doesn't feel right to me. There's two types of preparation. There's administrative preparation and there's psychological preparation. And the counselor or the licensed practitioner very, very, very much needs to be a part of the psychological preparation, because that involves going over their trauma history, making sure they understand what to expect, making sure that they know what to, like managing expectations, helping them understand, to lean into the experience, all that stuff. Whereas administrative preparation is more like, where it's going to be, how long it's going to take place. There needs to be kind of both. I'm actually gonna, I don't know if it'll let me put a photo in the chat, but I presented to the education committee about the difference between these and how we need to have both administrative and psychological prep, as well as administrative and psychological integration. And I think that just very much needs to be included in the practitioner piece. So I'm gonna go ahead and see if I can post that picture now.
Yeah, I went ahead and updated practitioner to where did I just put it? That they must be involved in psychological preparation, and then I changed in facilitator, it's conduct administrative preparation sessions in coordination with the psychedelic therapist. Is that kind of what you were envisioning, or do I need to change the language?
Let me see that. So yes, and integration, right? So preparation, I think you already had integration in there, but I just want to make sure that we're also keeping that within the scope of practice, meaning that, the facilitator isn't going to be doing the psychological prep. They're going to be doing the administrative prep. Anyway, just want to make sure that those are clarified and people understand that those are two totally different things.
So conduct administrative preparation and integration sessions in coordination with the psychedelic therapist?
Perfect. Yes.
Cool. All right. And then Gina?
Gina, your mic has been enabled. Unmute yourself when you're ready. Sometimes, Gina, if you're able to log on and off, or also if we can put the phone number in the chat if that doesn't work, you can call in. You can also type in your comments into the chat if that's helpful.
And then while we are waiting for her to type up her comments, Chris?
So just going back to what Catherine said, and I'm not sure I disagree, but I just want to have a little bit of discussion around that. Like the practitioner could also and probably would be a facilitator as well, and in that they are assigning the, how do you have it termed up there? You say they assign the clinical tier, right? And so I think for less complicated cases, the facilitator might be able to handle all that prep work. But that's just something I wanted to bring to the table.
Yeah, and I think that that would actually go in line with what Catherine said. So the comparison of like what is on a list and if we're looking at their history would be administrative prep. It's checking one list against another list. And then that the actual like psychological goals, intentions, setting that would be done by a licensed like therapist or other provider. And then from there, that person could do both. It's just depending on what how involved they are in actually setting like patient expectations, intentions, and cognitive processing. All right, and then I am going. All right, and then I went ahead and updated the definition to be what Denali had said. So means an individual who has completed department-approved training and education and has been registered with the department and whose role is limited to providing non-clinical support and presence to a patient preparing for, experiencing the effects of, and integrating the effects of administration as allowed by the program. A guide does not, or facilitator does not perform and shall not be construed to perform clinical assessment, diagnosis, treatment, or any other act constituting the practice of medicine, nursing, or other licensed health profession. A guide does not act under the supervision, direction, or authority of any licensed healthcare provider, and no provider shall be deemed to have supervisory responsibility over a guide solely by virtue of their concurrent participation in any part of the program. Cool. All right, I will go ahead and paste the
Ian, if you would also, there's a comment in chat about changing guide back, change guide to a facilitator in the bottom of the paragraph.
Change those last appearances of guide. Yes, here. Let me just.
It's in there twice.
Cool.
There you go. Thank you.
And thank you for pointing that out, Denali. I had not seen that. There was still remnants, so I do appreciate that. Cool. So let me go ahead and paste this in the chat. Alrighty, so with this whole document now, I'm just going to ask if there's any more discussion, questions, things that they believe need to be changed. Any other discussion to be had about these clinical roles? Alrighty, then we will go ahead and take a vote on the clinical roles. All those in favor of adopting the clinical roles as posted in the chat and appears on the shared screen, please raise your hand at this time.
Sorry, Ian, there's a comment. Can I sit with this? Is the question by Greg in the chat.
So what we can do, realistically, not too much changed. So I'm just going to go ahead and move forward with a vote. On the discussion, we just went over it, so I'm gonna still proceed with the vote. If you are in favor of adoption of these clinical roles, please raise your hand at this time.
Three hands.
Perfect. And then please lower your hands at this time. Kate, did you have a question? Oh, never mind. Alrighty, and then if you are against these clinical roles, please raise your hand at this time.
I see one hand.
3-1, the clinical roles are adopted. Now we can go ahead and move on to the preparation part of this document. I'm really curious to see how we can integrate the differences between administrative prep and psychological prep that Catherine had brought up, because I had not considered that at the time of writing. So I'm just gonna give y'all a heads up that we may need to make changes. So preparation. Consistent with the Medical Psilocybin Act, a qualified patient must be determined to be medically appropriate for treatment by a psychedelic therapist. Facilitators operate within their defined scope and do not assume responsibilities related to clinical appropriateness, dosing, or medical safety planning. So for the preparation sessions, patients shall initially complete at least 2 preparation sessions, totaling no less than 3 hours. I believe in a prior meeting we changed that to 2. I will keep it as 3 until we discuss it more. Hours prior to administration, initially this limit may be reduced if repeating dosing, with each session lasting at least 1 hour, with the final preparation session occurring no less than 24 hours and no more than 60 days prior to administration. Where feasible, 1 hour of preparation shall be in person. Participation shall be conducted by a facilitator present during administration. And the preparation may occur via telehealth when clinically appropriate and shall be documented in the patient record. All right. Anyone have any questions, comments, concerns about that first paragraph? Chris?
You know, I wonder if we shouldn't put in here that, you know, these are kind of the bare minimum requirements. I think, and I'm not sure, you know, I know we've kind of assigned the clinical rules where, you know, the tiers will be established for patients, but, you know, patients with complex PTSD might require much more preparation than this. But I don't also want to create barriers and to access. So, yeah, I just, I wonder if it should be noted that it is a minimum requirement, not necessarily reflective of what patients should get as far as preparation.
Perfect. So I went ahead and added that minimum preparation session requirements, floor, not a ceiling, is what we listed below. And then is that kind of what you had in mind, or? Perfect. All right. And then Gregory?
I think it would behoove the program to write it as language where the number of sessions is deferred to the decision of the whomever makes that decision. And that way, as things shift and change and new roles come out, you don't have to rewrite the rule every single time. Because there may be conditions in the future that allow for a brief introduction, and there could be much more complicated sessions that require years. So it's like, if we constrain it here, we box ourselves in. But if we defer it to the broader deciding, like the qualified decision makers that we are defining in the previous section, then we have more flexibility. But just a recommendation.
Yeah, so it would say, like, here's a general standard clinical decision making can be used to change these amounts, basically, is what you're recommending?
Well, I mean, we decide who gets to make the decision, and we write the language that defers that preparation time, the preparation context, to the professional who's qualified to make that decision. It doesn't need to be like, we don't need to define what preparation sessions are. We just need to define the box in which they're guided. It's just a different approach of writing it.
Yeah, no, I could.
I don't have I can work on language and send a recommendation, but that's just like the perspective I'm coming from.
Yeah, we're more of a clinical judgment side, and I do agree with widening clinical judgment. So Let's hear from a couple of other people, but I do think that that could work. Denali?
Yeah, I think this is kind of related to Gregory's comment. I think we have to make a decision, and maybe this is something where the department's perspective would be helpful. I'd been operating under the assumption that some of the care model protocols won't actually live in rule, but will live in departmental guidance, which I think is helpful for a couple of reasons, because one, it's a lot easier to change as evidence of what, is best practices. We're not going to be required to go through rulemaking process to adapt to new evidence. But I think whether our recommendations here live in rule or in like internal DOH guidelines for clinicians, we may want to consider something that's come up in other subcommittees of, we have 4 very distinct diagnoses and qualifying conditions, and I think it's appropriate to recognize that the care of each will be different. And so to Chris's point, maybe for PTSD, we require more intervention. Maybe also we consider, whether the role of a non-clinical facilitator is appropriate for every indication or not. I think that's an important question for us to consider. And, the department, with the input of the advisory board, retains the ability to add new qualifying conditions. And what we don't want to do is create regulations that don't allow for future indications. I know someone in the last, or maybe the last, not the last meeting, but the meeting before that, was from the Psychedelic Pain Association. And I know a major challenge for pain patients in trying to move through both Oregon and Colorado's regulated systems is that, it just isn't clinically necessary for someone who's moving, not for a behavioral health indication, but for pain management, to have a prep session before each administration session. That is completely different for someone who's moving for any behavioral health indication. I'm packing a lot into my response, but I think in general, right, I want us to consider whether it makes sense to think about best practices as being specific to each existing indication, and then, have in our mind what the burden both on the advisory board and department would be to make sure that those regulations or requirements reflect what is clinically appropriate for not yet qualified, but likely to be qualified at some point in the future indications.
Yeah, so I do concur, but I see that Dominic has his hand up, so he might be able to provide clarification.
Yeah, thank you, Ian. And yes, Denali, you are making a very clear distinction between what would be guidance or recommendations from the department for best practices versus rule. So as far as the actual treatment of patients, every patient is going to be a little different. And someone said it in the chat, I kind of lost thread on it for a moment there, but where the actual treatment in and of itself is really going to be up to the licensed individual, so the practitioners. And so we do need to have the discussions with regard to this so that we know what to put forth as far as for best practices and for guidance, especially for people and clinicians and practitioners and facilitators who are going to be new to this, to help them and to help as far as from a training perspective as to what is going to be necessary and needed. However, from a rule point, it really just outlines here are what essentially the job duties are. So for example, for the practitioner would be helping to ensure with the care team that the care being provided, is going to be the best possible for that patient. And of course, trying to convert that into a rule rule appropriate language is a little more difficult than just saying it the way I am here right now. But that is essentially the intent. The rule sets that framework, but the actual treatment really should be up to the practitioner. So for example, we don't turn around and say in rules and things like that, that for example, for cardiac surgery, you must use this procedure. That may change in a year. That may change in 6 months. That's going to depend upon the condition of the patient. And so that is not the point and the intent of the rule here to say that for individual patients, this should be exactly what the treatment looks like. We should have some guidance and some guidelines on that, but that part does not go in rule. The rule is, here are what the responsibilities of those providers, practitioners, facilitators are, and then the actual care itself should be left up to that care team. I hope that makes sense. And I hope that helped clarify a lot of this. But the discussions still need to happen because we still need to do that guidance. That just won't be part of the rule aspect. So thank you for pointing that out as well, Denali.
Perfect. And then I see Gregory's hand up.
I have no idea why that was. Probably leftover.
No worries, Chris. Oh, Catherine.
Yes, I just want to kind of speak a little bit to what everybody has been talking about and what I put in the chat. I actually do think that for new clients that have never, especially somebody who's never had this experience before, I think 2 psychological preps are needed and 1 administration prep. And then I also just want to kind of go back to what was being said here. I do think the practitioner should be the one that makes the decision. There are protocols out there right now by Johns Hopkins that shows that 2 doses, macrodoses, can help with treatment-resistant depression. And those doses can be anywhere from, I have one article that says 2 weeks apart, which is not what I would recommend. But they could be 4 to 6 to 8 weeks apart. And I don't think you need as much prep for the second one as you do for the first one. So there's just an example, even just using the qualifying conditions, where I don't know if you would need, to do 2 or 3 preps for the second journey, which is spaced months apart. You still will need a prep session, but I don't know if you'll need 3. And then, of course, as chronic pain comes on, chronic pain is one of these things where you're not needing as much prep as well. So I just want to point all of that out. I really like this idea of maybe making it the practitioner's responsibility, and then we offer guidance, through education as to what that should actually look like. So thank you.
Perfect. And then hearing from you guys, I went ahead and changed that first paragraph to just be 1 sentence. The amount of psychological preparation shall be determined by the psychedelic therapist. Does anyone have an addition to that, or
I would
have
also
better
just,
verbiage?
at some point, we do need to specify there should be at least 1 admin prep always for the facilitator. Because you always need 1 prep for admin with respect to, what time of the day it's going to be, when the prep, when, what the setting and the set and all that's going to be looking like. So I think you need both. Thank you.
All right. So the amount of psychological preparation time shall be determined by the psychedelic therapist. The administrative preparation can be determined by the facilitator. Does that sound good to everyone? Or
Except that I do think there needs to be an admin prep always. Like, I think we need to require at least 1 admin prep, because even if you get it done at the same location, you still need to go over all the things to make sure that they're understanding everything that's going to happen. And I'm actually thinking the admin prep should be, oh, I see, you put it under prep session. So yeah, that works. I just think we need to have at least 1 admin prep, and then the psychological prep is obviously determined on a case by case basis. That's just my 2 cents.
Should we put like, not to constrain them, but should we put like a limit and say, we'll set your psychological prep can be good for 90 days, but after that we need to assess what your new intentions are. How have you moved through your goals and that kind of thing, if it is going to be a repetitive dosing?
Right. And I think intentions and all that is part of should be part of psychological prep, in my opinion. But I agree. I think there needs to be at least one of each before, and actually sometimes they can be combined if it's done by the facilitator. There's so many pieces here to look at.
So in my mind, what I'm thinking is like the psychological preparation time. I think we should do a psychological preparation session is good for administration up to 90 days post session, post preparation. And then the administrative preparation can be determined by the facilitator or can be performed by the
Like they could
facilitator.
even be combined depending on the situation and the person. I do think though this is going to require some time for us to process. Just saying.
Oh,
'cause-
absolutely.
Yeah, okay.
We have like half an hour left. There's no way we're making it
Right.
preparation. But I just don't want to get your words wrong and then have to summarize it after the meeting. So are you thinking like at least one preparation session before each, at least one admin prep before each?
Here's how I think. There needs to be at least one preparation session before each treatment. They can be combined. Admin and psychological can be combined, but you do need at least one prep session for every single treatment. If they've already been treated before, I think combining the two can make sense because you're updating their intentions, you're making sure they understand any differences that are going to happen this time versus last time. So I don't know, maybe we need to have like definitions for first time versus subsequent times, right? Like, because the first time I still do think you need 2 psychological and 1 admin. And then subsequent, you may not need as many depending on the situation. I don't know. Again, a lot to think about right now.
Perfect. And then Gregory had some comments.
I'm gonna kind of say again, like I don't have the language pinned down here, but I think that this whole section can be 2 sentences. We need to zoom out because right now we're trying to figure out what all the minutia and what all the different possibilities and variant edge cases are. That is not the job of this document, in my perspective. Please, I open argument and conversation on that. All of this can be handled by, we need this type of thing, this type of thing, this type of thing. These are the types of people that are allowed to make that directive. There are so many variables, and we are not only are we not going to figure out that in this session, we are not qualified to make those decisions. Like that work is down. Well, yeah, maybe there are people in this room that are qualified to make those decisions, but those decisions are not really the directive of this document. In my opinion, it needs to zoom way out. And that might get us through this more easily.
Perfect. Thank you. And then Chris?
I'm sorry, Ian, I don't remember what I was going to say.
No worries, it's a Monday. All right, and then Catherine. Alrighty. So what we are going to do, in order to better find a way to phrase this, I'm going to take what Catherine said, and what Gregory said and prepare a new preparation document. No clinical roles document will have changed. It will just be the preparation to adapt to the role changes and the comments that were made. But I think we are at a pretty good pausing point just because I prepared the preparation document before the changes to the clinical roles. So this would give me a chance to make sure that everything aligns and also to add in what we have discussed at this meeting. Does anyone have any objection to that, Chris?
I don't have any objection to that. I was gonna make one recommendation though, Ian.
Yeah.
I wonder if we shouldn't call a brief advisory board meeting soon to get the clinical roles over to Brenda in an approved fashion. That way she can start working on that. I'd hate for her to start working on it and then it, come back to the advisory board and not get approved.
What is the minimum amount of, Dominic, when would the department be available for like an impromptu advisory board?
Yeah, I don't know that that's necessary. There is the advisory board on the 15th, and I think that that would be sufficient if you want to cover it and include it on that agenda.
I would be okay with that. Brenda, does that work for you if you're still in this meeting? I do not think she is. Then we will go ahead and keep it just so
She
that
is,
we
Ian.
don't.
She is
Oh,
still in
cool.
the meeting.
Yeah, she responded yes in the chat.
Perfect. All right, then we will go ahead and take it up on the 15th. And then we can do a really quick one. I'll go ahead and transmit it to the rest of the board following the closure of this meeting, and then we can work on preparation. Let's see, when can we do our next meeting? Calendar. Right. So I am busy Monday the 11th. Can you guys do Tuesday the 5th? Any objection to that? No. Not seeing any. All right, Tuesday the 5th at 9 if that works for the department.
Or you're not getting an answer from me because my computer is locked and I can't check the calendar. Dominic.
No worries, Jorge. I was actually just logging on in, and I just give me a moment because our system seemed to decide right at that moment to block us all, it appears.
You too.
Here
There's
we go.
no
Yeah, but
advisory
I'm back
board.
in now.
There's no advisory board meetings. I don't know what else the department might have done.
Yeah, no, it looks like the Tuesday the 5th at 9 a.m. starting at 9 will work. From a department level, we do have a meeting at 10. So if we could do that as a shorter meeting, do a 9 to 10, that would work for us. And then on that side.
Yeah, and then I think because we're going to be stripping away a lot of the requirements and leaving the clinical judgment, that should work. So we'll go ahead and do Tuesday the 5th.
At 9 a.m. And we'll get that invite out and posted as usual.
All right. Well, perfect. Thank you guys all so much for coming. I really appreciate you spending the morning with us. I appreciate all of your opinions and everyone who spoke today. Thank you guys so much for being here. We wouldn't be able to make this program without y'all, so thank you. Have a great rest of your week and cheers.
Thank you, everybody. Have a great day.